I think that needs to advance one slide there. Thank you. And then one more. And then as we proceed towards the end of the operation, we take out all of the support structures to the side of the uterus. This would be the broad ligament or the perimetrium. None of that would be performed in a conventional hysterectomy. People who are not experienced with treating cancers will sometimes make the error of performing a regular simple hysterectomy to treat cervical cancer. If we do this operation where we remove all of the perimetrium and the upper vagina so that we get a wide margin of healthy tissue, the chance that a patient will be cured of her cancer is about 96%. It's very high. But if we did a simple hysterectomy and neglected to remove these extra structures, the chance of cure is only 30%. So it's very important for people to understand the distinction between radical hysterectomy and conventional hysterectomy. And this sometimes gets lost by people who are not taking care of cancer patients on a regular basis. We are doing, I'll skip one slide, we're doing many of these operations with laparoscopy now. And so when the radical hysterectomy operation was first pioneered by Wertheim in the 1890s, these were all laparotomies, and that continued until the early 1990s, almost 100 years. But over the last 20 years, most of these operations are done laparoscopically. We can do a complete radical hysterectomy where we remove the uterus, the ligaments, and the lymph nodes laparoscopically, or we could also do things as a trachelectomy that you heard this morning. Now, I'll show you some actual images in just a moment, but schematically, what a trachelectomy is we remove the cervix, we remove the upper vagina, we remove the ligaments, and we remove the lymph nodes. But what we don't remove is we don't remove the upper portion of the uterus. That remains inside and can be reconnected to the vagina so that a woman can retain her fertility even though we have done a radical operation to remove the cancer. This is not an operation that can be offered to every woman with cancer of the cervix, and I'll talk about that in a moment. Now, this slide is to show you how thoroughly we can do our dissections with the laparoscope. I haven't done an open laparotomy for radical hysterectomy now in a number of years. It's almost never. We would sometimes do it if our patient has a very large uterus. Perhaps she has uterine leiomyoma and has cervical cancer. But in most settings, we do it laparoscopically. This is showing the dissection in process. This shows a view of the pelvis after the radical hysterectomy is done.